We'll begin. Our moderator for today's panel is Esther Rhee. Esther is the National Program Director of Autism Speaks Canada. Ms. Rhee oversees the Family Services Program in Canada, which focuses on increasing programs and resources for families. Through the Family Service Community Grants Program, Esther has supported the distribution of over $3.5 million across Canada to increase programs for individuals with autism and their families. Esther also sits on the Autism Speaks Global Science team, which has supported over $200 million towards autism research internationally. Additionally, Esther collaborates on provincial and national advisory committees and alliances. Esther's work in the ASD community has focused on building community capacity, collaboration, program development and navigation, and supporting strategies. Please welcome Esther Rhee.
Thank you so much. I actually didn't realize that there was going to be a bio that was presented, and then I feel really bad because I actually scrapped all of the panelists' bios and introductions. So it just gets so long at a certain point. So my name's Esther. I'm so glad to be here. Second year in a row now that I get to moderate this exciting panel and joined by some really pivotal leaders in this community. I'm excited for the discussion that we're going to have. We're going to focus today on, obviously, access. We're going to talk about increasing access. Particularly, we're going to focus on some of the challenges and the barriers, and through multiple perspectives. So we're going to take a look at things like local, national, global trends. We're going to take a look at different sectors. We're going to talk about what's critical for individual and family support. And overall, we're going to have a really engaging discussion. We're joined here by some panelists that were here last year, if you were here. We have some new faces on the panel as well. And I'm excited to just get started and dive right in. There's a lot to cover. I know that we're a little bit behind schedule, so I'm going to do my best to kind of bring us back to schedule so that we end on time today. So you'll see me kind of trying to manage time as well. If there's somebody else in the audience that can give me a little bit of a heads up, that would be really helpful too. But as I said, I did actually scrap the intro part because it would take a considerable amount of time off the panel. But what I'm going to do is actually ask everyone to do a very quick high-level introduction of yourself, 20, 30 seconds, let the audience know who you are.
Hi, I'm Jill Farber, Autism Speaks Canada Executive Director. I'm excited to be here. We've been supporting SAC and the development right from Gita's basement. So we're super proud to be a partner and super proud to be here. So thanks for having me.
Hi, I've just spoken. I'm Vikram Patel. I'm a psychiatrist and I work at Harvard Medical School and with Sangat in India, and my main interest you've already heard about.
I've got this one here. Mike Lake, Member of Parliament from Alberta. So I'm wearing the Alberta shirt because somehow that allows me to rationalize the fact that in the middle of an election campaign, I'm here in Ontario. Actually, my daughter bought me this shirt the other day, and she bought herself the same shirt. So she's 20 years old now, and I think it's pretty cool that she wants to wear a matching shirt with her dad. And I'll tell a quick story just because I'm a little bit lost without Jayden or any video of Jayden here. So I'm going to tell a story about Janae quickly. Because we were doing an interview, some of you have seen this interview a couple of years ago with Steve Paikin, and Steve asked Janae, who was 13, and Jayden was sitting right there. Jayden was 16. He's now 23, my son. Steve asked her, Janae, I'm going to ask you a really tough question. Do you ever sometimes wish your brother was quote unquote normal, like every other kid? And Janae at 13, without skipping a beat, said, well, honestly, since Jayden was diagnosed with autism before I was born, I don't exactly know what a normal brother is like. So Jayden kind of is my normal, having autism. And I love the fact that after 13 years as a member of parliament, the smartest words ever spoken in an interview that I've been a part of were spoken by my 13-year-old daughter.
I'm Catherine Yu. I am a family physician in the community of Thorncliffe Park. I am a mother of 3, one of whom has autism. I am also a medical director for Health Access Thorncliffe Park. And my role is really around establishing a model of care that increases access to care for the entire neighborhood. And as a family doctor, we look after everyone from cradle to grave. So while I'm here in a very special conference about autism, I also carry some of the work for access in terms of other populations as well.
Hi, I'm Mark Spoelstra, and I'm the Executive Director of Autism Ontario, and delighted to be a partner with SAC on this conference today. I work for an organization that represents families across the province of Ontario through 25 chapters, and we try to get to every corner of the province and find ways to connect with families and connect families with each other, and to provide information, supports, and public advocacy.
That's great. Thanks, everyone. So actually, Catherine, maybe if you hold on to the mic, I might start with you, because we're going to dive right into talking about system models. And you mentioned in your introduction that that's actually something that you do in your role. So what would you say is critical when we're taking a look at developing models of support? How do we ensure that we're getting it right? What kind of things go into consideration in the work that you do?
Yeah, so I just met the panelists, and in fact, Jill and I just had a brief chat before coming here on the stage. I'd like to preface what I say with the fact that I think the ideal model of care in terms of delivering care really is very much whatever the community actually brings to you as what's most important to them. Having said that, that's a broad response. I do believe that there are 4 critical aspects of a good model of care. The aspects that I am more biased towards, of course, is the health aspect in terms of having a primary care delivery model in the neighborhood. Primary care is very important in anchoring the care of the child, but as well as the rest of the family members, because often I think we look after a child and we know that there are many issues that their parents face in terms of their own health. And if you anchor care within primary care, then you're able to also, in a more fulsome way, address that. So that was one piece. The second piece I feel is important is the partnership with the education sector. So in our work in Thorncliffe Park, I can speak to that, is that the school is a very critical partner to our work. The children that we see are in school every day. So 8 hours a day, 5 days a week. And the work that we do can only be really impactful if we're actually working together with the school providers. The third aspect that I would say that is very important is the availability of a hospital resource partner. Again, our work in Thorncliffe Park involves very much the Michael Garron Hospital Specialist Group. As part of their strategy is building community, and they've therefore asked their departments of family practice and pediatrics to really strongly support our work of delivering care within the neighborhood. And that has been key to us, and I think you'll hear more about that perhaps in the talk that I will also be giving after this panel. And the fourth aspect that I want to take one more minute of this panel's time to share is that I think it's very important to partner with a community agency or a number of community agencies. And it really depends locally what community agencies are strong in that neighborhood. So for our neighborhood, there's many different strong organizations. SAC has been one of the organizations that we've closely partnered with. And there's also the neighborhood organization. And their role really is around helping us with the social determinants of health. A big piece around what we do is making sure that all the non-medical pieces that we need to work with our patients around are addressed by resources within the community.
That's great. Thanks, Catherine. It really showcases the strength of a collaborative model as well. So maybe I'll turn to Jill, actually, and talk about what's your view in terms of how we build models across Canada?
So I'm going to feed off of yours a little bit, but I think I like to coin well, I'm not coining it, but someone else coined it before me, ecosystem. So let's think about the whole ecosystem when we think about the right model of care. So who are involved? It goes right from the researchers to making sure that we're using evidence-based information, right down to the community, as you identified. If I'll take it out of the example of the child and put it into an adult with autism. And if we think of the right model of care for an adult or someone who's transitioning into adulthood, how do we think about the community? How do we think about employers? How do we think about the other employers around, so their colleagues, family, of course, and having that person-centered approach. So around this person, what's the ecosystem around that person, and how do we build a model based on a real ecosystem approach an ecosystem where we take everybody into consideration and how is everybody going to have that important impact. So I think when you're building models, I think you're not only thinking or talking about the person, but everybody around the person as well.
Great, thanks. And Mike, I'd love to hear Marg's actually perspective, because I know you do so much community and family work. What's important when we're thinking about building systems models?
I brought my book up with me because there's a quote from a family that I've been inspired by recently. And it goes like this. It's a dad talking. Bringing up a child with autism is hard, not because he has autism and is neurodivergent, but because as parents we are having to fight a system that forgets us and him, financially hits us, builds barriers around us, and stereotypes us and our children. My son is not hard work. Fighting against a system that excludes him at every turn is. And that statement to me just speaks to some of the pain that's there, but it's not, this quote doesn't talk about get me this health service, get me that service. It speaks about the society in which that child and family live and exist. So part of any healthcare system, first of all, in my mind, is, and what parents tell us consistently, is finding ways to care for those caregivers. And that means that in any system in which we create as a society, we need to be thinking about whether that is specifically healthcare, whether that's in early intervention, early diagnosis, mental health supports. Who are the people with whom they're interacting? And I really appreciated your presentation, Dr. Patel, in thinking about how do we get to the people who are on the front line and dealing with people at a generalization of skills level, and that both partner with parents, sit on the bed together, which was, I love that picture. People just sitting there and saying, okay, this is what our family life looks like. How do we work together to embrace what's real here? So any health system has to talk about the people of that society and what they think is valuable in other people and what it means to have relationships that value that child and that family's experience as part of what it means to be human. And so if we think about healthcare systems and we build them, there needs to be training about who we value. So whether you're talking about an educational assistant, a healthcare person who is at a very early entry level, someone who's in a helping profession of any sort, that they're thinking about people always as someone who belongs in the society and deserves to have the rights to the same privileges of being human and in a society, in a societal context. So I think those systems that this dad is talking about only reflect who we are and what we say to one another about people who are neurodivergent and how we think about where they belong and how that person deserves or not our attention, whether that's in a hospital and listening to those families and listening to their personal experiences, or whether they're in a school and entering that for the first time or in a high school year or beyond, and what it means to belong in society. So to me, that is fundamental to health of a community and thinking about those key points.
Thanks, Marg. And that quote, actually, it's so powerful. It actually transitions us really nicely into the next question, which focuses on barriers, right? And so we know that there's a number of barriers in terms of access, whether some common ones are funding or geography or capacity, training you touched on as well. Catherine, maybe we'll start with you again. What are you seeing in your practice as some of the trends in terms of the barriers to access?
There are many. I'm wondering where I can focus on. I think in my succeeding talk, I wanted to talk about the different levels in terms of the barriers. There's the micro and the meso and the macro level. And I think I can speak a bit more to the macro level, perhaps because I've got a politician sitting beside me. It might help in terms of future policies as well. At the macro level, I think a large barrier that we do encounter is the fact that different organizations, so I was talking earlier about gathering together a model of care from the health, social, and education sectors. We are all funded differently. We work within different privacy policies. And these types of rules and templates that we have to work around as individual organizations are a real barrier to the integrated model of work. And just to speak to some of what Mark has mentioned, for the experience of the family, they want to actually, and this is our model in Thorncliffe Park, we hope that when they knock on our door, it's the one door that they're going to need to knock on, and that it opens all the doors everywhere. And I think that for us in the front line to be able to actually execute on that, the policies around privacy and the funding need to actually check in with each other, depending, wherever your funding comes from, whether it's from the Ministry of Health or others, that they are not they're not actually contributing to competition between different organizations, because at that level, you can already feel that access becomes an issue.
Great, thank you. Mike, do you want to, I didn't know if you took the mic because you wanted to comment on that as well.
I mean, I'm glad to quickly comment just the fact that no matter where it is that you are in the world, really, but in North America particularly, this decision as to where autism lies, whether it's health or social services or education, as Catherine mentioned, that conversation's existing everywhere, and we have to do a much better job of bringing ministers together, ministries together to have that conversation across government so that we're having a more comprehensive approach. Likewise, we need to think beyond the specific place that our loved one is, or if we are an individual with autism, where we are in our lifespan, and think of our approach as a lifespan-oriented approach, including diagnosis and early intervention and education and vocation and housing, and what happens when the parents are gone, because that's the terrifying thing for those that are parents in the room. The thing that keeps us awake at night is what happens when we're not there anymore for our loved ones.
And maybe if we pass the mic down to Vikram. Vikram, you've done so much international work, and your presentation really highlighted that, the local-based support services that you're building, really, and the global impact as well. Are you seeing similar trends that we're talking about here today at the conference around barriers to access, the need for interdisciplinary, coordinated, collaborative support, or do you find that these trends actually change depending on where you're working?
So there is some similarity, of course, but obviously in many of the contexts I work in, there is no system. The only system that exists is your family, your neighbors, and if you're lucky, a community that is engaging with you. So I think maybe one of the lessons for me is how not to build a system, which is full of barriers, but instead to anticipate them as you build a system from the ground up. And if I had to think through the families that I've spoken to and encountered, maybe the real challenge for families is navigation. Because it sounds to me the problem sometimes of too much is that you don't know where you go. The problem of too little is, of course, there's too little, but at least you know where it is. And I wonder whether sometimes, and I'll invoke my colleague Paul Farmer, who uses the word accompaniment, which I think is a really nice word, because it suggests that what you're doing is not treating someone, you're not helping someone, you're not being generous to someone, you're just accompanying the person. You're accompanying the person through the journey of their life, because autism is not a disease in the sense that, it doesn't have a beginning and an end in that sense. And I wonder whether the idea of accompaniment is one that is needed here, one in which every family has a person that family knows will be with them through the journey of autism, help navigate them, help communicate them with, or coordinate all these multiple sectors. And the question that I struggle with is, what is the correct sector that should actually support that? Should it be child welfare? Maybe not so appropriate once you become an adolescent. Should it be education? Not so appropriate when you leave education. I don't know where it sits. Maybe the health sector, but I'm a little uncomfortable about the health sector being the primary node, because that perpetuates, I feel, a somewhat sort of disease model. But all I'm going to end by saying is the idea of our community health worker approach is the idea that is embedded with that notion of accompanying you through the course of your health issues, your social difficulties, etc., being by your side, having a person you can call whenever you need some advice, guidance, support, accompaniment to go to the office to get your benefits, etc.
Right. Yeah, language is so important in this context as well, and so really encouraging us to be mindful of that, right? I want to go a little bit deeper in terms of the context of challenges and barriers. So let's break this down by sector. If we take a look at education or health or social services, what are you seeing? Catherine, the mic's back to you naturally, so let's start with you again. Are you seeing different trends in terms of the challenges based on sector? So does education come with its own set of challenges versus if you're looking at the healthcare sector versus if you're accessing social services support? Are you seeing differences depending on the sector that families are trying to access support from?
Sure, and I'm not sure if I can speak to broad terms. However, I can speak to some of our experience in terms of the challenges, for example, in the education sector. First of all, I want to preface this as we've really had a great relationship with the TDSB, and they've been very collaborative, and we're very fortunate to have them as strong partners in our model of care in the neighborhood. One particular barrier that I alluded to earlier was this privacy issue. We are, in the beginning of our partnerships, we were all very skittish about sharing information because we work in different, around privacy rules. So privacy rules in health, as most of you would know, would be very different from privacy rules in the education system. I think that if we end up really being too worried and scared about what we can share, then it really inhibits us from actually providing the care that we want to provide to our patients. But at the same time, we want to be very respectful of the reasons why these privacy laws were put into place. So that's one in terms of the education sector. In terms of the healthcare sector, and maybe I'll bring it back to what Dr. Patel had said, when we think about who should probably lead the area in terms of access. Maybe my own bias and pitch is that health should. However, you're right, medicalizing everything in health is probably the wrong way to go. I think that I also teach in the Department of Family and Community Medicine here at the University of Toronto, and we are gearing our education in the past 3 years more towards the recognition that the social determinants of health piece is so much more an important part of the illness experience. So I think that we're talking about barriers, but I'm thinking now of enablers. Like we acknowledge that our lack of scope and skill in terms of working or helping our patients in the social determinants of health aspects are difficult, but we are working on it. We are actually trying to educate the newer doctors, the younger generation, to be really cognizant of the fact that it's not really, we're not working now on a disease model. We're working on a whole person, what community they're in, who's around them, who's their family, and their day-to-day lives.
Thank you. And you brought up the good, an important conversation around strong partnerships too, right? And that could be a panel discussion all in and of itself. Marg, you see families all the time. You see them trying to access and navigate the system and trying to access information that may be, quite difficult to access. Are you finding differences in terms of what type of support or what age group or anything like that? What are you noticing and observing and hearing from families?
We hear from families that there's still a need for everything. So I don't say that in a disheartened way, but we still have a fair way to go. But what I do hear is that parents are telling stories more often about things that do work well. So they're talking about an experience in education where the teacher was alongside, the principal was on board, and a team got around and surrounded them in that classroom, and they had peer mentors within school settings, and we hear those stories. But the opposite is that we also hear the stories that frighten us all. And so then I think, are we in the same province? So I know we know what needs to be done. We know how to be with one another and to support one another. We have the professional tools. We know what the evidence says, but somehow we're not able to do that in a way that's equitable. And so I think, and obviously from the slides we saw this morning, we have such a long way to go in these areas, but we know that there are stories of where it is going well. So that is one of the things that families are telling us. I would say we're also hearing parents talk about a better conversation when they're getting an initial diagnosis. So I see some of that improving, and I do hear families also say, you wouldn't believe what they did for us. My kid was having a meltdown in the ER, and they responded with care, compassion, and excellence. And our experience at the hospital was one we couldn't have imagined before. And just to listen to that tells me that at the end of education for healthcare professionals, that it's having an impact. So we know it can happen. I would say uniformly there is still a real challenge in education, particularly as children are getting older and starting to exit, and families really talk about that cliff when they move out of education to having no clue about what can happen next. And again, there are people trying to make those changes, and we're seeing that, but I think the adult years is a scary time. And those stories are the ones where families are saying, I don't know where to turn. I need that ministry of being alongside someone, and that has disappeared. So even in their inadequacy sometimes in education, it's still a system that can be supportive. But when you move on into those adult years, parents are on their own again, and autistic adults are saying, I need knowledgeable professionals to help me. And we heard that in our survey of parents across the province as well.
Catherine, did you want to add to that? Thanks, Mark, for that insight.
Yes, I wanted just to add to that because I think that this is an important piece in terms of why primary care needs to be at an anchor partner in integrated care. So when as primary care physicians, we look after patients from cradle to grave. And so this whole worry around what then after you go into adulthood is something that we really would like to be helpful in. You know, kids graduate from SK elementary school, but they never graduate from their family doctor. So if we can partner appropriately and build our skills in primary care, I think we can really help with the issue around transition to the next level of care.
Great, thank you. I'm going to switch gears a little bit, and maybe we'll pass the mic down to Jill, and still focusing on the topic around challenges, but let's take a look at scope and geography and scale. So are you noticing in the work that you're doing any challenges and differences when we're taking a look at local versus national versus global systems and support models?
Yeah, I think at every level you're going to have differences, but what we're trying to do at our organization is really think globally but act locally. So taking programs and thinking how they're going to impact those big global issues, but impact them at a local level. And even once impacting them at a local level, make impact at a national level. So I'll give an example. So the CST program, something that Vikram has been a part of as an advisor, I think, very much similar to some of the things that you heard Vikram speak about today. So it's the caregiver skills training. So who is that accompaniment? And I have a question for you. Can that accompaniment be the parent, right? In some cases, in some communities, does that work? And so taking the parents and really making sure that at a local level within their community that they have the skills to assist or accompany, I'm going to try to change my language a little bit, their child and then moving on and their young adult or adult. And so really this skills training program is for a very young age group of children, but really having the child and the parent at the center and making sure that they're both armed with the tools that they need. And so it's really, really thinking locally because you're impacting this within the home, but at a global level because we're all talking about the importance of the accompaniment and the importance of training and skills for parents and community, really. So CST is an affordable and accessible, so those are two words that you used earlier, so an affordable and accessible intervention that we can act locally, but really think at a global level. We've taken it with McGill University, and we've introduced 5 new rural and remote organizations in Canada and are now funding 5 rural and remote organizations in Canada that wouldn't necessarily get the services that we know here in the Greater Toronto area, but providing them with this skill training, a skill training person in their community who can then train others within their community. So replicating that to start locally and then and grow bigger, but in a rural and remote. So very much not totally like the communities that you're living in, but similar within a Canadian environment. So. You know, do I see differences do I see differences locally, nationally, and globally? Sure. But I think when we look at those global issues, we have to think, how are we impacting at a local level? So that's what we're trying to do. We're always trying to think globally or nationally, but impact at a local level.
Great, thanks. And maybe if we can pass the mic down to Vikram. Vikram, you spoke about this in your presentation as well, but I'm just wondering if there's any advice or any additional thoughts that you can provide from us from the learnings that you've come across when we're taking a look at trying to have like threads in all 3 of those areas in the work that we're doing. So impacting the families in the local community while we're taking a look at, you know, here in Canada, a national autism strategy is often something that's being talked about nowadays with the federal election happening versus global issues that the global autism community is going through. Are there learnings that you can share, any advice for us in terms of how to move forward with that?
So I'm not sure I'd really have a straightforward answer to that very complex question. But what I will say is that there is something that unifies autism no matter where you live. And that is the fact that this is ultimately a family-centered issue. It's not even a person-centered issue. I think especially for children with autism, this affects the family in ways that actually is very similar in many parts of the world. It's ironic that you hear similar experiences in very well-resourced settings that resonate with low-resource settings. And that has to do, I believe, with very fundamental personal experiences of living with a child with autism, which are universal to the experience of being a parent, I think. This is a speculation. And having said that, I think the key lesson I would say is keep your eyes and minds open to what's happening in low-resource settings, because in there might lie ideas and innovations. Some of the best innovations emerge in constrained resource context, but they're not just poor ideas for poor people. Actually, they could be very good ideas for all people. And I think in trying to sort of reverse engineer some of the innovations in resource-poor settings to resource-rich settings, you might come up with very novel ways of thinking. And I think one example, very specific example, is the community health worker. And I completely agree with you about primary care, actually. In India, the community health workers are connected to the node of primary care. And actually, they do have an accompaniment model. And what is that accompaniment model? Each community health worker has 500 households. And she, it's always a she, because that's the way India's community health worker is structured, basically has a responsibility to accompany those 500 households for the rest of time. And when she retires, those 500 households go handed over to her successor. And in that household, she supports the family in everything that the family needs, which of course, when it comes to the case of autism, which will affect maybe only 1 or 2 or 3 of those families, or maybe 5, she will then also perhaps coordinate their care with whatever other agencies. So what you saw in the New Delhi scale-up, it's exactly that model. It's with those community health workers who are responsible to accompany 500 households, named households, that are allocated to her until she retires.
Mike, you've done a lot of work on all 3 levels. You also bring the perspective of a parent as well and a family member. What have you observed around this type of work that's happening? What advice and notes do you have for us?
It's interesting. I love the conversation about the 3 different levels. And I love where Vikram's going with the community health worker. So I've got a chance. My official capacity for the last, up until 6 months ago, was in international development, actually. And I've had the chance to go to Africa 3 times and work with organizations like World Vision and Plan and Save the Children and UNICEF. And I find that when we're talking about the national autism strategy, we tend to engage autism stakeholders and have that conversation with autism stakeholders. But as we engage in the global autism partnership concept, and Vikram's been a part of that conversation, we start to engage some others, and we found real success. One of my favorite quotes is JFK, "Things do not happen, things are made to happen." And I found that we were spinning our wheels like we do sometimes at the federal level on autism, as we've talked about national strategy, when we talked about a global autism partnership. And it's just recently that I was on a trip to Ghana a couple of years ago, and we started to embrace this idea, could we have impact if we just focused on one area first to start, rather than try and solve everything all at once, which we're prone to try and do? What if we just focused on Ghana? And so we've been having this conversation now involving Autism Speaks and Pam and Andy, and involving World Vision and Plan and Save the Children, the Global Partnership for Education, which is like a $3 billion organization focused on education around the world. And so it's not just autism organizations. And I was really inspired listening to Vikram's presentation as he was talking about these tablets and the sort of use of technology in dealing with remote settings, because all of these organizations, Plan, Save the Children, UNICEF, World Vision, they have remote offices in Ghana and countries around the world. These community health workers are out getting to know the families, and they know everybody in the community. What if you used the expertise we have in this room? I'm thinking about Louis and Nancy and Mohammed and others in this room. What if we remotely trained community health workers to understand what autism looks like, whether it's called autism or not, just understand what it looks like, and to understand what it is that might be done if you encounter someone that has the symptoms that go along with autism, how you might help them. And there's a real power to that. And so what we learn in that, I think that the way I kind of think about global versus national is I kind of think about it as like inhaling and exhaling. If you've got a national autism strategy, a group of people in Canada working on autism, they inhale the best evidence from around the world, right, and exhale it into policy in Canada, having impact here. And then you inhale the very best that Canadians have to offer and know, and you exhale that globally so the global community can benefit from it.
Thanks, Mike. I'm going to get you to pass the mic to Jill. And then Vikram, I'd love to hear your thoughts on this question too. We're going to move on to the topics around culture and race. And so what role do you see culture and race playing when we're talking about the development of services and supports for families? What's important for us to be mindful of, but also what is not involved in the conversation that we should be talking about when we're, and so specifically around culture and race. Jill?
I'll come to an example because I'm always better when I give an example, but I think that most importantly, when we're talking about culture and race, we have to think about that, and I'll give you another term, but that inclusive by design. So rather than sort of a plug-in, rather than thinking about culture and race later, rather than making it work with the system that we have or the model that we have, how are we building these things inclusive by design? So how are we looking at it straight from the consensus, the consensus of yes, this is what we should have, and have we considered, and I'll even bring in the social determinants of health, but have we considered all of those social determinants of health? So including culture and race and gender, and have we considered them in the design? And if we're just plugging them in because we want to do something, then we haven't necessarily considered them in the design. And so I think we need to be, what are we missing? I think we need to be a lot more thoughtful about inclusive by design. So again, I'll give you an example. With SAC, we have funded MDoc. So MDoc is I'm not going to get it right, Keita, but it's a program that is basically a mobile assessment of families. So they go to the family's home and they do assessments in the community. So why is that culturally by design? Why is that respectful, culturally respectful by design? Because they're thinking about the people that they're working with or working for or to collaborating with, the families, and how are we going to best accommodate, I'm trying to change all my language, but accommodate those families by the design or model that we bring out. And so why we decided to fund something like that, because we did really believe that they took these social determinants, the race, the culture, even the gender for that matter, because we were not seeing the girls in the South Asian community being diagnosed. And so how do we make sure that that's embedded in what we're building and the models that we're building? So I think that that's really important. I thought that was a very good example of how we embed and make it a culturally designed, respectful program or model. Vikram said something today that sort of I'm reminded of is where, why, who, and how. So where is best to do it? So when I talk about inclusive by design, we have to think about those questions. Where are we doing it? Why are we doing it? How are we doing it? And who are we doing it with or for? And so making sure that all of those models in design are really touching those important factors like culture and race. And I'm going to add gender because I think it's important. So how are we making sure that all of those factors or determinants are embedded in our models, or making sure that the funders are thinking about those things when the applications come our way.
And Vikram, I'd love to hear from you as well. We've talked about it and threaded through all of our presentations today. We started off with our first presentation that really talked about the impact around culturally sensitive and how we do that mindfully. What are some of the learnings that you've had? You've worked with so many different groups and communities. What are some of the insights that you have to share on how we go about moving forward and being culturally sensitive in the service that's being provided?
So, first of all, can I just say that one of the interesting things about the conversations about culture is that it doesn't happen that much in the Global South. It's a very peculiar thing. I don't know why. I come from a country where we have, innumerable languages and cultural groups, but no one ever talks about culture because it's assumed that all Indians have some common culture. So it's a very peculiar thing. I think for most of the Global South, the issue is social class. I think that is what really drives much of the thinking about inequity. Of course, social class does intersect with certain ethnicities in all parts of the world. But by and large, there are poor people everywhere, people who are disadvantaged because of their economic position. And they often share a lot in common in terms of their experiences of healthcare, the system, by and large, being excluded, etc. As a guiding principle, everything we do is guided by the principle of co-production, which I'm sure many of you will have heard of. The idea, again, nothing about us without us really, that everything we plan in terms of design must be co-produced with the people that we are supposedly trying to reach to. And that means involving them, I think you said it exactly right from the start, even defining what is it that you actually want fixed. Because if I go in with a particular, seeing the problem through my particular prism, I may actually miss what it is that the so-called target community actually wants to have some resolution or some degree of support for. The second is delivery. How can you play a role in delivery? And third is how can you hold the system accountable? And so essentially having that community involved right through that process is a guiding principle. And I think if we do that, many of the challenges associated with race and culture would hopefully be incorporated, provided you actually construct a co-production group that is representative of the community you're trying to address.
Great, thanks so much, Vikram. Mike, you took the mic, and I'm actually going to start with you for the last question. So our last question is actually going to focus on the topic around care coordination and case management. So two critical areas when we're taking a look at supporting the individual and their family. So maybe, I don't know what lens you want to use, but I know that you've gone through the system in Alberta with Jaden as well. And so what are critical factors when you're building a care coordination and case management system? What needs to be included to succeed in terms of supporting and assisting families?
So I'm going to actually start by just kind of commenting on the conversation just before this. That for me, what's helpful to kind of visualize all of these big questions is the idea of meeting people where they're at, right? Wherever they're at, wherever they come from, what stage of life they're in, whatever their challenges are. I just think about the challenges that I have in my life, things that sometimes cause me pain, or that I want people to understand them. I want people to make an effort before they just try and impose some solution on me. I'd like them to try and understand where I'm coming from. And so, to your question, as I kind of think about that, in Jayden's world, where we've had great success is when the groups of people that typically operate independently from each other actually communicate with each other and work together. And we start to think of Jayden as an individual human being instead of a kid in an early intervention program, and then a kid that seems to be a completely different kid in the education system, a kid that's a completely different kid that we treat differently when he goes to the doctor, and then when he turns 18, he's suddenly a different kid, and he's not a kid anymore, he's an adult, and these are very arbitrary transitions for Jayden. We have to do a much better job, I spoke of it earlier, but we have to do a much better job of having our different constructs, because really when you think about political departments and ministries, wherever you are, they're just constructs. They're not real. What's real is the person. What's real is Jayden and what he's having a challenge with that day. And we need to do a much better job of coming together in Jayden's interest and trying to help him. And so that might mean that the aide that's working with him in the school system is communicating with the people that have been providing his early intervention program and continued to while he was in school. That it might mean that the psychologist that he went to at the Glenrose is communicating in some way with the person that's running his program. It means that his pediatrician needed to be in contact with the people that were working with him, and everybody kind of has to have an understanding of Jayden as a person. And too often we just take Jayden and we hand him off, right? Like he's no longer in this program anymore. He's now over here and dealing with a system that has never met him before, and we have to start again. And as parents, you're dealing with so much. As families, you're dealing with so much. We find ourselves constantly having to start at ground zero and explain again. And there's no need for that. And I think Catherine talked about some of that in the sense of sort of privacy and information sharing. We have to, it's one government department, then another government department, then another government department. If you've got privacy concerns, surely you can deal with them at a government level as opposed to department by department by department. And I see a lot of people nodding their heads because they've gone through the same cycle over and over and over again. It's not something that just exists in Ontario or Alberta or whatever the case is. It's something that exists around the world, and we need to do a better job of it. And hopefully, one of the things, I'm not going to get political here because it's kind of interesting. We're at a great place in time in Canada where I think all three of our major parties are going to have national autism strategies in their platform. So that's a good thing. We want to try and differentiate and fight and whatever the case is. So it is something to celebrate. And I don't tell anyone I said this, but no matter who gets elected, hopefully we should have a momentum towards a national autism strategy regardless. So I'll leave it at that.
Thanks, Mike. I'm just being mindful of time. Maybe if we pass the mic down to Jill.
Mark hasn't spoken. Or you can pass it.
You are. Wait, let me do a time check. I wanted Jill to comment on the case coordination and care models and what we need to be insightful around as well. So any advice that you have for us, maybe we'll leave this in terms of the final comment before we wrap up the panel today.
Mark, do you want to take? I'm overpowering Esther. Should I give it to Mark? Because we haven't heard from Mark in a while.
If you want to pass it up to Mark, go ahead. I thought maybe this would be one you want to answer, but go ahead. This is live on the spot, everyone.
I'll say a word and then I'll let you say a word because I haven't heard from you in a while. So I think that something around case coordination and case management, following on what Mike said, we have to have a continuum of care. So we can't stop the care, and to what Catherine said, is we can't stop the care. Primary health caregivers can have that continuum of care, but even outside of that primary caregiver, there has to be that continuum of care, that there's like a baton that's sort of going off, and making sure that the right questions are asked. So making sure that, when we're handing the baton, that maybe that primary caregiver has the information, but that the right questions for the continuum continues, if that makes sense. So that the questions that you would have asked 5 years ago are not going to be the same questions that you're going to ask 5 years for the next 5 years of life. And so making sure that there's a continuum and that there's the right questions are being asked. Can I hand it to Mark?
So many good things have already been said by the parents who live this every day. I'm going to say a few quick things. Listening to families, and not that as an afterthought, and giving them access to the things they need when they need it. And also teaching them to be the best possible advocates, because at the end of the day, and particularly because women still take on the majority of this role, and we saw the stats again. I keep thinking about these stats I saw this morning and thinking we have so much more to do. But if we can continue to have parents supporting parents and having frameworks in which you are able to advocate effectively for what you need, and that as a system we believe that matters, and that we put our money where our mouth is on saying that what families say that they need for them and their children matters and should be supported. And I think I'm going to leave it there.
Thanks, Mark. I know Mike wants to also add into this. We've opened up the floor.
No, the only thing I want to, just because I want to underscore what Vikram said a couple of times, and we're a panel up here with nobody with autism on it. We need to be listening to people with autism. I'm feeling a little bit self-conscious. Yeah, I'm feeling a little. I don't present very often without having a video of Jaden, and that's very deliberate, because Jaden, without saying a word, can articulate more what it's like to be Jaden than I can as his parent try and articulate that. And so we need to include people with autism in these conversations.
Thanks, Mike. I'm actually really glad that you added that thought. So I hope that was as enlightening for you as it was for me. Lots for us to think about. If you can join me in giving a round of applause to our panelists today. Thanks, everyone.